As per the PCNA Psychiatric Clinics of North America, the burden of mental disorders such as depression and anxiety, they fall disproportionately on women of childbearing and child-rearing age. Women's mental health is everyone's business. Why? I would like this session to be a little bit interactive also. Can anybody please give your inputs? Why women's mental health is everyone's business? Yeah, because I think everybody knows that. Everybody knows the answer. Isn't it? Yeah. Because if a woman is unhealthy, is mentally sick, is mentally unwell, mentally unsound, then it leads to problem in the whole family, and that dissipates to the community level, whole society. So women's mental health really affects mental health and physical health of everyone around her. Mental health is a term used to describe either a level of cognitive or emotional well-being or an absence of a mental disorder. From perspectives of positive psychology, mental health may include an individual's ability to enjoy life and procure a balance between life activities and psychological resilience. Okay? And psychological resilience, as you all know, is the ability to mentally or emotionally cope with a crisis and to return to pre-crisis state quickly, to bounce back. And usually the mental and the behavioral processes and the behavioral capabilities that allow the person in promoting personal assets and protecting them from potential negative effects of stressors. It is basically how to remain calm during the crisis and to move on without any long-term consequences. Okay, so this is psychological resilience. Why emphasis on women's mental health? Gender is a critical determinant of mental health and mental illness. There are differences on the basis of genders. There are varied manifestations. There are many differences as far as the patterns of psychological distress and psychological disorders are concerned. There is higher mean level of externalizing disorders. Higher mean level of, the opposite I have written, higher mean level of internalizing disorders in women in comparison to externalizing disorders. Externalizing disorders are more common in men, whereas internalizing disorders are more common in women. Yeah.
Some mic is unmute, ma'am. I would request all the participants to kindly mute their mic, ma'am. माइक जो ऑन है ना उसकी वजह से वो हो रहा है मैम, इको हो रहा है थोड़ा. काइंडली अनम्यूट द माइक ना.
Unmute or mute?
All the participants are requested to. All the participants are requested to mute your mics.
Am I audible to everybody?
Yes, ma'am, you're audible.
Okay, very nice. Okay, so the patterns of psychological distress and psychological disorders, they are different in women in comparison to men, and there are higher mean level of internalizing disorders. This is a typo error, you can say it's a mistake, than the externalizing ones. Externalizing ones are more common in male gender. Internalizing ones are more common in female gender, like depression, anxiety, the common mental disorders. While the externalizing, like ASPD and all, they are more common in male gender. Gender differences are based on physical, physiological, and psychological attributes. Okay, and there are, as we all know, there are culturally prescribed different gender roles, and there are certain gender roles specific to females. There is a thing called alpha bias that proposes that men and women are different and they are opposite. Okay, and this bias is used in the psychodynamic theories, and so the beta bias, differences are ignored, and that is applicable in cognitive and humanistic existential theory. So these are differences between genders. Okay, so we put more emphasis on women's mental health because the manifestations of psychological distress, there are differences in the way both the genders they communicate, how they deal in the relationship, how they express their feelings, react to stress, And based on these physiological and psychological attributes, there are marked differences as far as the women are concerned and the male genders are concerned. Now the statistics. 1 in 5 women, they experience a common mental disorder. Common mental disorders like depression, anxiety, the anxiety spectrum disorders, compared with 1 in 8 men. There is a clear evidence indicating women's mental health is linked to their experiences of violence and abuse. The lifetime prevalence of violence against women is quite high. It ranges from 16% to 50%. 1 in 5 women suffer rape or attempted rape in their lifetime. And as we all know, the common mental disorders are markedly more common in women, and unipolar depression is twice as common in women. Now the psychiatric diagnosis in women. The rates of severe mental illness are similar in both the genders, but there are differences in the age of onset of symptoms. There are differences in the frequency of psychotic symptoms, the course, the long-term outcome of SMIs, severe mental illnesses. They are different in both the genders. The rates of major depression in dysthymia, they are about twice as high. They are twice as high for women as it is twice as high for women as for men. And prevalence rates for most anxiety disorders like panic disorder, agoraphobia, specific phobia, generalized anxiety disorder. I hope, Sashi, you are sharing all the slides.
Yes, ma'am.
Okay?
Yes, ma'am.
Very nice. Very nice. These prevalence rates of most of the anxiety disorders, they are 2 to 3 times higher in women. And the exceptions are OCD and social phobia. The rates are approximately equal. But in most of the anxiety disorders, they are 2 to 3 fold more prevalent in females. Bipolar disorder, type 1 rates are equal in both the genders, but the type 2 bipolar disorder, which includes hypomania and the depressive symptoms, they are more common in women. And in women, more mixed episodes are found. Rapid cycling is more. Rapid cycling is if there are more than 4 episodes in 1 year. The later age of onset in bipolar disorder and more depressive episodes are found in females. In schizophrenia, as we have all seen at SMIs, in SMIs the rates are almost equal. The lifetime prevalence is equal. Although the course, the women have later age of onset and they have bimodal distribution. There are 2 peaks, the early peak and the midlife peak. And there is higher premorbid functioning and the social functioning. The prognosis is better in females and it has more benign course. Eating disorders like anorexia and nervosa, they are more prevalent, much more prevalent in female gender. Substance use is a little bit, it's lesser in female, and men are 2 to 4 times more likely to have diagnosis of substance use and dependence. But women with affective illnesses, the mood disorders, they are more vulnerable. Personality disorders more common in women are borderline and histrionic personality disorder. They are more commonly seen or maybe more diagnosed in females, as we frequently come across in our clinical setup. Men show more of antisocial personality, narcissistic personality, and OCPD, obsessive compulsive personality disorder. Females have more rates of sexual violence, and so it has been found that they have higher rates of PTSD. Again, the female sexual dysfunction is largely an unexplored entity, although a little bit of studies have been done, and more so in the culture-bound syndrome. Heart syndrome has been studied in great detail in many of the literatures, many of the research articles we can find, but female heart syndrome, that is largely unexplored area. Now, as we see in the psychiatric diagnosis, in major depressive disorder, females have, they are more prevalent in females. Then the dysthymic disorder, seasonal affective disorder, premenstrual dysphoric disorder, of course, it will be in female, and bipolar disorder. Okay. Women and depression. Women are more prone to develop depression because of their biological vulnerability, because of the reproductive life cycle, and because of the psychosocial factors. So, what are the biological vulnerability? First, we deal with the psychosocial risk factors. They are gender-based violence like rape, sexual abuse, domestic violence, socioeconomic status. They are more dependent. The caregiving responsibilities are more of females, and they have to play multiple roles in the family. Then there is one very interesting and very important model of depression, that is learned helplessness model of depression. That is the animal model of depression that was given by Martin Seligman. When a person learns that their attempts to escape negative situations, if they make no difference, that person becomes passive and he will endure aversive stimuli or environment even when escape is possible. So it was seen that when an animal is given electric shock, he is kept in a cage, he is given electric shock, repetitive electric shock, and he is making frantic efforts to escape. But if he is not able to escape, in spite of his repeated attempts, then it has been found that later on he gives up. He doesn't take any efforts to escape the situation, even if the escape is available, even if he is given a route to escape. Similar thing is found in females. If they are subject to domestic violence or the intimate partner violence, and later on they become so accustomed to it, even initially they had made frantic efforts, but later on they just keep residing in that situation. They don't try to come out of it. Psychosocial risk factors that are unique to Indian scenario. Dowry is a malpractice that is quite prevalent in India, and that leads to a great deal of psychological distress, and maybe sometimes risk factor for may act as trigger for depressive episode. Marriage leading to uprooting of female from family of origin. That is very peculiar to Indian scenario, that after marriage, the female, she gets uprooted from the family of origin, she gets totally cut off from her family in which she was born. Pressure to bear male child, that is quite prevalent till date in our society. Normalization of domestic violence. Females, they feel that domestic violence is a normal thing. There's nothing abnormal about it. Pressure to conform, to stay submissive. Gender roles like childbearing, rearing, doing all household chores. Even if the female is having a great career, even a female is bearing responsibilities outside home, if she is doing any kind of job, but still the household chores, the childbearing, child rearing is considered to be female's primary responsibility. That leads to the kind of stressful situation, and it leads to a great deal of kind of strain on her. Husbands or partners, they don't act as allies. More so in India. It is usually seen, not everywhere, but it is seen in India. And the Indian paradox. Indian paradox has been used in one of the articles I have seen. That is a very interesting term. It shows that married women with severe mental illnesses, they are subjected to domestic violence. They make frantic efforts. They still make frantic efforts for restitution of conjugal rights rather than trying for separation or divorce. So a female if she's having severe mental illness, she is subjected to domestic violence, but still she makes efforts to restitute her conjugal rights, and she doesn't at all doesn't fight for a separation or divorce. That is quite peculiar to India. Now the reproductive events related to psychiatric disorders in women. The menstrual cycle, infertility, pregnancy, postpartum period, menopausal transition, perimenopause, and hormonal therapies. Hormones and mood. Higher incidence of major depressive disorder in women, they start at puberty. It has been seen that during puberty, the common mental disorders, the onset of mental illnesses, they are more common. The female are more prone to, in fact, 4 times more prone to develop these disorders in comparison to males. puberty acts as a very vulnerable period. Less marked as postmenopausal period. Suicidal behaviors may be more common in low estrogen states. It has been found in many of the researchers, even the recent research done in 2015 and 2019, it shows that the suicidal behavior is found in the low when the estradiol levels are lower in the blood, and that leads to decreased serotonergic nerve conduction, and that may lead to suicidal behaviors. And the rates of the postpartum admission in psychosis, it is elevated immediately after childbirth, and the perimenopausal mood disorders versus postmenopausal mood disorders. Now we see that during the puberty there is spike in the major depressive episode hazard rates, and that continues till the age of the perimenopausal, the 45, 49 and 50 years of age. That was shown by the Kessler et al. In 1993. Now the suicide in the menstrual cycles, there have been various studies, and the recent studies have also been run, Zengin et al. In 2015. And he emphasized the fact that the estradiol levels, they contribute to decreased serotonergic nerve transmission, and the perimenstrual weeks, the weeks before and during menstruation, suicidal behaviors are found to be more common. So it is more related to the estrogen level. As we see that estrogen level, there are various studies, as you can see on both the sides of the picture, the follicular phase and the luteal phase, and all these studies, they emphasize the fact that menstrual cycle, they are positively correlated with the suicide attempts and changes in estrogen concentration during the cycle. Shashi, can you please handle for a while, for just 1 minute, okay?
Yeah, ma'am.
I'm sorry.
So the level of estrogen, it is correlated with the suicidal risk also, and at different different time of menstrual cycle, the rate of suicide increases, and there is variation in the rate of suicide at various time of the menstrual cycle. We will wait just 1 minute, ma'am will come.
Sorry to.
Yeah, ma'am.
It was a little bit. Okay, I'm resuming. Yeah, so the phases of menstrual cycle, they are positively correlated with suicide attempts and changes in estrogen concentration. If the estradiol levels, they decrease, they contribute to decreased serotonergic nerve conduction. The childbirth and risk for psychiatric admissions. As we see that immediately childbirth, the admissions, there is hike in the admission rate. Okay, the need for admission was immediately hiked immediately after the childbirth. So childbirth is a risk factor for psychiatric admission. Hormones and mood, estrogen, progesterone, FSH, LH, testosterone, HCG and prolactin, they are all involved in the causation of mood swings, mood changes, and may lead to mood disorders as well. The neurohormones in the CNS, as I've already told you, that estrogen that decreases the MAO level and catechol-methyl transferase level, it decreases the level of these enzymes, and that leads to increase in serotonin level. So estrogen leads to enhancement of serotonin level, and progesterone that increases the MAO and COMT levels, and it leads to decrease in the serotonin 5-hydroxytryptamine serotonin level, it decreases. Okay, so estrogen is protective as far as the mood disorders and the suicidal behaviors are concerned. So this is how the tryptophan, it enters the neuronal cells, and how estrogen and progesterone they play a role. They have a role to play, how they deal with the MAO and COMT, and finally how the serotonin level is finally increased in the synaptic cleft. So the ovarian and the menstrual cycle, we see that how the LHFSH hormone plays the role in the ovarian and the menstrual cycle. How there is a LHFSH surge, and then the level falls and the menstruation occurs, and the estrogen level is built up, and how the progesterone level is built up in the later half, and that leads to changes in the uterine endometrium. Now the premenstrual symptoms and premenstrual dysphoric disorder. Premenstrual symptoms and premenstrual dysphoric disorder is a disorder. Well, the premenstrual symptoms are some of the symptoms if present. So if these symptoms, 5 out of these symptoms, if they are present in the final week just before the onset of menses, and they disappear after the menses. Okay, the follicular phase is totally symptom free. Then it is premenstrual dysphoric disorder. The psychological symptoms may include depression, anger, irritability, affective lability, anxiety, sensitivity to rejection, poor concentration, sense of feeling overwhelmed, social withdrawal, and there may be many physical symptoms as well, like lethargy or fatigue, sleep disturbance, usually hypersomnia is there, appetite disturbance, that is, appetite is usually increased. There can be abdominal bloating, breast tenderness can be there, muscle aches and joint pain, and swelling of extremities. Premenstrual dysphoric disorder, it affects 3 to 8% of menstruating women, and symptoms they begin in the luteal phase and they resolve completely with the onset of menses. So the follicular phase, the initial 14 days, the person is, the girl is totally symptom free, and the luteal phase in the later half it appears, and just it resolves after the menses, after the onset of menses. More than equal to 5 symptoms in most of the cycles are present, and there is marked decrease in social and occupational functioning, and it is distinguished from the underlying mood disorder as there are no symptoms during the follicular phase, and the culprit is the abnormal serotonin neurotransmission. Again, the treatment is lifestyle intervention, the alternative therapies, psychotherapy, and SSRIs. Now, the menopause and the perimenopausal period, there is increased risk for first episode depression during menopausal transition. There is lower risk for first episode depression in postmenopausal women, but during the period of transition, the risk is markedly hiked. Women with a history of depression remain at risk for future episodes, and estrogen replacement, although it may be found to be effective for just mild symptoms, but not for major depressive episode. Physical and psychological changes that are associated with menopause are, as we see that in depression, the depressive symptoms, irritability, anhedonia, thoughts of death, feeling of worthlessness, and the low energy level, low concentration. There is an overlap between the menopausal, the symptoms like hot flushes, perspiration, and vaginal dryness, but the depressive feeling, the anhedonia, that is decreased interest in the pleasurable activities, thoughts of death, feelings of worthlessness, they are present in depression. So we can differentiate between whether it is the postmenopausal symptoms or the depression per se. Now, pregnancy and mood disorder. It is a common myth that people say that pregnancy may be a time of emotional well-being for women. It is a time when a child is born. It is a very happy moment for the whole family. Even for the women, it is a very happy moment. Then why? Why the emotional illness can occur at that point of time? So everybody thinks that pregnancy is a very happy moment and it is a time of emotional well-being of women. So this is the hormonal surge which occurs in the initial phase. The HCG levels hikes, and in the trimester, the progesterone level and the estrogen level. Pregnancy, it is not protective against psychiatric illness. And rates of major depression during pregnancy is 10 to 15%. And anxiety disorders, the rates may be even higher. And during pregnancy, there is high rates of relapse when antidepressant medications they are stopped during pregnancy. Okay, 50 to 70% rate of relapse when antidepressant medications they are stopped during pregnancy. And the pregnant bipolar women they have the same risk for relapse of medication as non-pregnant women, and more so the postpartum risk. The weeks after the delivery, they are 4 times more risk to develop bipolar episode. So pregnancy is not a protective. It is not protective against psychiatric illness. The major depression, anxiety, the rates increase. Okay, there is high rate of relapse if the medications are stopped. The pregnant bipolar women they are more prone to develop episodes if they don't take medications, and the postpartum risk is markedly higher. Okay, even in the OPD we see that the postpartum psychosis or the postpartum mood episodes we commonly come across in the OPD or the consultation licensed psychiatry. It is usually called from the gynae department. Risk factors for depression in pregnancy. These are the risk factors. If there is past history of depression, if the overall health is poor, the alcohol use is there, smoking is there, if a person is unmarried and if she gets pregnant, she's unemployed, having lower educational levels, then they are more prone to develop depression. Now the risk of untreated depression and anxiety in pregnancy. The levels of suffering that is markedly high for mother as well as the partner. There is decreased ability to take care for herself and the pregnancy. The suicide risk is very much increased if the depression and anxiety is untreated. Increased risk for preterm delivery, preeclampsia and low birth weight. If mother is untreated, if she is depressed, then it may lead to preterm delivery, preeclampsia and low birth weight. And there is, if a depressed female is getting pregnant, then there are higher rates of smoking and alcohol and substance use. And the risk of postpartum depression markedly increases, and it leads to negative effects on child and family. It is even seen that if mother is depressed, then we call it analytic depression, and there is we see a change in the behavior of the infants. Okay, if mother is depressed, she's not able to. She's not responsive to the baby. She's not able to take proper care of the baby. Then the infant develops analytic depression, and in the later period of life, he may be more prone to develop depressive episodes. So, a mother should be protected from the depressive episodes, and it should be adequately treated during pregnancy as well. And of course, after delivery also. Depression in pregnancy, there are treatment options, the non-pharmacological options like psychotherapy, like CBT, light therapy, omega-3 fatty acids, psychosocial. Now the contentious issue, depression in pregnancy, the treatment options. The psychotropic medications in pregnancy, are they safe? No psychotropes have been FDA approved for use during pregnancy. And all medications, they cross this placenta. So the principles of management should be to weigh risk-benefit ratio, maximize non-medication options, and relatively safer medications, preferably the category C ones, that should be given in proper doses. Sometimes it is very essential to give medications, and the compliance should be properly checked. Because if the medications are stopped, then that may lead to relapse of the relapse of depressive episodes. So medications should be given in proper doses and for control of symptoms, and withdrawal of psychotropes may be detrimental to both maternal and fetal outcome. But of course, medication should be given with proper regular antenatal checkups. Okay. Now the SSRIs, the selective serotonin reuptake inhibitors in pregnancy, they have not been found to increase in overall rate of fetal malformations. Although some evidence is there for some of the SSRIs like paroxetine, There is mixed evidence on birth weight, early pregnancy loss, preterm labor with the SSRIs used in pregnancy. And there are evidences of neonatal abstinence syndrome, persistent pulmonary hypertension of the newborn. But there's no evidence of long-term developmental effects in children exposed in utero. So proper balance of risk benefit should be maintained, and it should be properly weighed. The pros and cons should be properly weighed, and it should be properly documented on the prescription that all the pros and cons have been explained to the patient. The regular ANCs have been advised, and the side effects of all the medications have been properly explained, and the dose should be minimal, and the safest drug should be given which have no or least teratogenicity, and it should be properly measured. The pros and cons should be properly measured, and they should be properly explained to the patient as well. The postpartum period, that is a continuum. It can range from the baby blues to the post, that is the normal thing, baby blues, postpartum depression, and the extreme form is postpartum psychosis. Has increased markedly. I think, yeah. Postpartum blues and baby blues, they occur in 50 to 85% of women. They are characterized by mood lability, tearfulness, anxiety, and irritability. And the symptoms peak at day 4 to 5. Day 4 to 5, the symptoms peak, and they may last for a few hours or to several days. And the symptoms, they do not interfere with the functioning, and reassurance is just required, and not the treatment is not required. Postpartum blues is not a disorder. But if the symptoms persist for more than 2 weeks, then the patient should be evaluated for a more serious disorder. The postpartum psychosis is a serious mental illness. It occurs in 1 or 2 per 1,000 women. We get calls from the OBS department, and the female is usually in a very poor shape. She is not taking care of the baby. She is sometimes homicidal towards the baby. She wants to kill the baby, and she may not be able to. She doesn't take care of the baby. She's in a very poor shape. So these cases are we come across in the clinical setup as well, and the onset is from the 24 hours to 3 weeks postpartum. There is rapid mood swings, insomnia, obsessive thoughts can be there, delusion, hallucination, impaired reality testing, delusion involving infant are common. There can be confusion-like states, disorganized behavior, and during that period, there is high risk of suicide as well as infanticide. It is a psychiatric emergency, and it needs evaluation immediately. And we should rule out all the differentials. And more than 70% they appear to be a presentation of bipolar disorder, which we have seen. The long-term course, maybe the patient is having the psychotic symptoms. Maybe we diagnose it as postpartum psychosis, but later on, she may develop bipolar disorder. Okay, so the more than 70% appears to be a presentation of bipolar disorder. Postpartum depression, the prevalence rate is between 10 to 15%, and the risk factors are the prior episodes of depression or anxiety, including during pregnancy, marital discord, unplanned pregnancy, infant medical problems, lack of psychosocial support, socioeconomic status, and we should rule out the differentials of anemia, diabetes, or hypothyroidism. The symptoms of depression, like depressed mood, suicidal thoughts, feelings of worthlessness, incompetence, guilt. The milder cases may postpartum depression, the milder cases may overlap with the normal feelings. The postpartum period, but hopelessness, worthlessness, suicidal ideations, they are not normal. They are not normal in the postpartum period. So, as soon as these symptoms are noticed, then the proper care, proper intervention should be done at the right earnest. Comorbid anxiety with obsessional thoughts about the baby is common, and we should distinguish it from the psychosis. There is one scale called Edinburgh Postnatal Depression Scale. Again, the postpartum depression, the treatment, as we do in the major depressive episode, the treatment is similar. But the role of improved social support, help with infant care, light therapy, and the medications like SSRIs can be prescribed, and benzodiazepines can be given for comorbid anxiety symptoms, of course, in low doses. The psychotropic medications and breastfeeding. All the psychotropic medications, they are secreted in breast milk. So it should be given. The concentration in breast milk, they may vary widely, and the peak concentrations they are attained at 6 to 8 hours. So the patient should be, or the family member should be properly explained that these medications can be secreted in the breast milk. So how to give them? So we usually say that the child can be top fed also and the breastfed also, and usually the just before the medications, the breastfeeding can be done. But if the infant is very at very initial stage, frequent breastfeeding, so we usually say to the family members as well as to the mother that the top feeding should be continued intermittently along with the breastfeeding. Careful monitoring of breastfed infants should be done, and the relationship between infant serum concentrations and infant physiology, behavior, and development is not clearly known. But the patient and the family member should be properly educated regarding that. How to breastfeed, how to top feed, and regarding the knowledge that the psychotropic medications, they are secreted in breast milk. Now, women mental health promotion. The first and the foremost thing in women mental health promotion is that men should act as ally to women in their mental health promotion. That is the most important thing, as it is my personal view also, that if men the mental health promotion of women cannot be attained. The psychosocial factors, if they are taken care of, the biological vulnerabilities, they may not manifest. Okay, the psychosocial factors are very pertinent. Girl child needs to be nurtured in a very positive and empowering way. Life skills, social skills, and assertiveness training, emotional regulation skills, besides providing the education to the girl child, is very, very important. The girl child, everybody in fact, and more so with the girl child, they should have the adaptive coping mechanism. They should be taught to develop healthy coping skills, financial independence, education about the legal rights like Domestic Violence Act, the POCSO Act, Marriage Act, Dowry Prohibition Act. They should be well informed. Women should give priority to their own mental health. In case of any difficulty, distress, or deviation, they should contact mental health professionals without delay. So, this is the last part. The mood and anxiety disorders, they are disproportionately, they affect women of reproductive age group. The times of hormonal change may be periods of particular vulnerability. So, the vulnerability starts from the puberty, and many women are reluctant to seek treatment. Diagnosis is often missed also by the physicians, the primary care physicians more so. Treatment of psychiatric illness is complicated by potential pregnancy and postpartum issues. Risks and benefits of both treatment and non-treatment should be carefully considered. The gender disparities should not be considered normative. Poverty, malnutrition, neglect, intimate partner violence have a bearing on mental health of women, and women should be properly educated regarding that. Women with mental health issues, they face much more stigma than men with same illness. So there is one term that has been used in one of the articles by Dr. Indira Sharma, the triple tragedy, that women having severe mental illness if they get married, they and if their marriage gets endangered or broken, then their lives are completely shattered beyond the point of repair. So this is a kind of triple tragedy which women having severe mental illnesses, if they are they face in the society, they are more stigmatized. If their marriages fail, their lives are shattered beyond repair. Women mental health is complementary to men mental health. So this is the concluding slide. The poem "Perfect Woman" by William Wordsworth that puts women on a pedestal: reason firm, the temperate will, the endurance, foresight, strength, and skill. A perfect woman, nobly planned to warn, to comfort, and command. So women are they are idealized, they are put on a pedestal, but still they are always judged. They are not given proper tools in this by the society. They are not empowered. So this is the complex situation. This is the complex scenario which puts women to more dangers and vulnerabilities to develop mental health issues. Thank you so much. Or anybody is having any question?
Thank you, ma'am. Thank you for such broad, and you included everything like pregnancy, menstrual
Yeah,
cycle, and
actually,
yeah,
Shashi, I
postpartum.
felt that just winding up this topic in just 1 hour is very difficult, and this is a very important topic. But still, I just tried to touch everything, whatever I could do. Thank you for your patient listening.
No, ma'am,
Yeah,
it was
yeah, Shashi, continue.
very exhaustive, ma'am, and everything was covered, ma'am. Thank you for that. And I think few places, I was like I could not share the slide properly. I am sorry for that. Now we can discuss the questions.
Okay.
Yes, ma'am.
Yeah.
There is one question from Sivika. Yeah, Sivika, you can ask.
No, I was just appreciating, ma'am, that this was much needed, and obviously, very rightly said that one can't cover it in just like a 1 hour session, but it was absolutely amazing, very insightful. Thank you.
Thank you. Thank you. Thank you, Shivika.
Yeah, Sivika, what is the question about postpartum depression?
Yeah.
She has asked what is
What is
So,
that? Postpartum depression?
no, while you were like telling about the pregnancy and women, so I was just writing postpartum depression. So, could you just like
Yeah.
brief a little about how to, like uh, kind of get out of it?
See, first of all, the symptoms of postpartum depression, the depressive symptoms are quite prominent. The first of all, you should rule out whether it is postpartum blues or depression, and all the differential should be properly ruled out. And more so if there is persistent, pervasive, depressed mood, irritability, and along with that, suicidality is there. So it is very clear that the person is having postpartum depression. And as the therapies are there for depression, major depressive episode, so also similar therapies can be given in postpartum depression. Besides that, the psychosocial support, the support from the partner, and the medications that should be safe, because lactating women will be secreting the SSRIs, the psychotropes and milk, that should be properly taken care of. And the psychosocial support is very important as far as postpartum depression is concerned. Of course, with the psychotherapy and the psychotropes and all that should be given. So it is quite similar as given in the major depressive episode. Shashi, would you like to add something to it?
Yeah, ma'am. Actually, soon after pregnancy, what happens that the female, the woman, first time she becomes a mother. So she is not fully confident that whether she may be able to take care of her child. She is This is a totally new environment for her, taking care of her child, and at the same time too much emotional and hormonal changes is going on in the body, because for taking care of the baby while pregnancy, the body has changed drastically in the 9 months, and now everything is coming back to normal. So emotional turmoil, more than that, responsibility increases, and also these hormonal changes. Along with that, the social support, all the members in the family, they are like happy. It is like now she has become a mother, and so they ignore the fear that the female has. Will I be able to take this responsibility properly, or if the child falls from my hand, what will happen to the child? So this kind of uh, social, what saying, learning that she had from childhood, this all predisposes to depression, particularly postpartum. And if the risk gets higher, then risk of psychosis, like she will start hallucinating, having delusions, this kind of things develop, and she may even stop feeding the child. She may not take food. So these all things happen with postpartum blues and postpartum depression and psychosis.
Yeah, Shashi, you have very rightly added. Yeah, one thing I would like to also add, I just forgot to add. See, during pregnancy, during the last trimester of pregnancy, and just after the delivery, till the baby is 3 months old. See, that is a state of chronic sleep deprivation for mother. So that also predisposes mother to varied psychiatric illnesses and mood lability and postpartum depression. So the chronic sleep deprived state and the suddenly the new role and the phase of nurturing a newborn child, feeding, and that is too taxing for a mother. So, of course, they all predispose her to develop the depression, the symptoms of depression. Rightly added, Shashi.
I hope
Thank
that
you so much, ma'am and sir. Great information. Absolutely, sir.
Dr. Manu, will you ask your question?
No, Dr. Manu will add his inputs. Why should he ask
No,
questions?
he has.
No. Like nothing much to be added. You people have covered it extensively in a very well. No, actually, I had a doubt with one of my patients a few months back. I guess I put it down in the message. Like a lady came with a son, saying that the son was like 10 to 12 years old, and his IQ was all like clinically he didn't seem to have any issues. And but she complained that the boy is having burning sensation in one side of his face and the same side of his body. I asked the child, like, what's happening? He said, like, no, I don't have any complaints. And I again asked the mother, she was explaining it so well, so vividly. I was wondering, like, what is this? I asked the child again whether he had complained anything of this sort to the mother. The child said that no, nothing. I was actually like taken aback, surprised. I wasn't able to understand what was going on. I further dig into the history. She started saying that as a mother, I can feel what the child goes through, though he doesn't say. I can feel his pain and all. I started understanding that there is some issue with her. I tried digging up more. She said that she also had experienced similar pain around like a couple of months ago, for which she visited multiple doctors, but she couldn't have any solution for her issues. So she can Shashi, please mute your phone.
Just 1 minute.
Shashi, sir, please mute your mic. Yeah.
Just 1 minute. We have some problem.
Shashi, mute your phone. Yeah. But then like, she was not ready to go without any treatment. So while I was wasn't able to find out what the gains were, like whether primary, secondary, nothing I could make out. She was saying that even the family, everything is fine and all. I'm not sure what was there in the family. She just wanted some treatment, so I just gave some multivitamins to the child because I didn't want to. I actually offered her treatment. She said that no, for me it is all fine now. I don't want any medicine. So I just gave multivitamins and asked them to return back in 10 days. In 10 days, she came back saying that, yeah, so everything has got better. There is no burning sensation at all. And all. On that day, again, I tried taking up more history, but again, I could not find out like if there was any gain associated with that. I couldn't say whether it was a malingering or a factitious disorder or what it was. Thereafter, those child and mother, they never returned back to my clinical place. I don't know what has happened with them. So, I don't know, if any of you can give your inputs regarding this case.
Roopam, ma'am?
Dr. Manu?
Yeah.
Actually, I couldn't hear your question properly, and it was we can just talk on that case later on. Yeah, yeah.
On the message, I have to keep down.
Okay. That needs a lot of evaluation, I think. The gains, the stressors, everything. That needs a great deal of sessions with the patient as well as the family member.
Yeah, that's all.
So,
It was like she just disappeared after that second visit, saying that everything had got better. Never to return back again.
and the CSA and all, have you ruled out? As far as I could gather, is there any history of CSA or something?
In her case, no, I didn't ask about that particular thing.
Okay.
I was just asking about any abuse, domestic violence, or anything of those sort. Because I couldn't corroborate any history from anybody, as she was all alone. Regarding the CSA, yeah, maybe I have missed out on that.
Okay.
Sorry for inconvenience. I was the culprit.
Okay.
Ma'am, this because the risk of depression, psychosis, neurotic disorders is very high. Uh, how to manage them other than pharmacology?
As I told you in mental health promotion,
Yeah, ma'am.
isn't it? The part to be played by the partner, the family members, the psychosocial, the support, and the early coping skills development, psychological, the resilience part, the whatever is written in the mental health promotion part. I think that if it is imparted in the very beginning, the
Yeah.
independence,
Yes.
the self-reliance, self-efficacy, the autonomy, so that the female feels that she has control over her day-to-day events. These things are very important for mental health promotion, for mental health of anyone. Why to talk about women? Anyone, but women are deprived of these basic rights. We see. Even today, it's very prevalent in society. Women are not given financial independence. They are discriminated at every level. There are workplace discrimination, harassment. So many. It's multifold, and the legal rights, everything. They should be well educated about that, and the everything is very important. And but most important is the the life skills development
assertiveness training. These are very, very important key skills that the women should develop, and they should be made to develop from the early childhood. So I think these things are key to mental health, and even during the phases of the crisis, even during the reproductive and mental health. The mental health has been it has just been limited to the reproductive cycle. In most of the studies, also in most of the area in which the people work, that is they just focus about the reproductive various reproductive cycles of a female. So that should not be the thing. Okay, reproductive cycles, they play a very important role. The hormonal surge, the hormonal changes, the various from puberty till the childbearing till the menopausal, postmenopausal. But besides that, the psychosocial aspect and the life skill development, they all are key to just mental health promotion. And with the psychosocial support, with the medications, with the proper intervention, timely intervention, with the legal rights provision, uh, mental health can be promoted and sustained.
So
I
the
think
yeah,
I've given the answer.
goal is like
Anyone else?
holistic approach, na ma'am. Not only
Yes, yes. Psychosocial. In
psychosocial
fact,
support,
the
financial,
triangular
yeah.
approach, the biopsychosocial model, the एंजल का जो दिया हुआ है ना, बायो
Yeah.
साइकोसोशल, बायोलॉजिकल वाला भी चीज कवर होना चाहिए, साइकोलॉजिकल और सोशल भी, सारा कुछ कवर होना चाहिए, तभी आप मेंटल रेजिलियंस और मेंटल हेल्थ प्रमोट कर सकते हो.
Okay, ma'am. Thank you, ma'am. Mm. I hope so. Today it is Mental Health Awareness Day, and more than 50 webinars we were discussing, na ma'am. Too many webinars are there today, ma'am.
Yes.
So they have.
Yeah. Yes. Yes. Any other question?
Ma'am, I don't think anyone has any question, ma'am, because Manu,
अच्छा ठीक है.
do you have any question?
No, nothing much. Yeah, it was a wonderful presentation.
Yeah, ma'am, it was like eye-opening presentation, holistic. Everything was covered, and this presentation can be used for this exam purpose actually.
अरे इतना भी अच्छा नहीं था, चलो भाई ठीक है.
सही में मैम.
Thank you.
Thank you, ma'am.
Thank you. At least I could deliver something. I could, yeah, impart something. Thank you for your input.
Yeah.
Absolutely, ma'am. Thank you so much.
Okay, shall we stop here, ma'am?
Yes, now it's over, I think, and today's wishing you all a very happy mental health day today.
Yeah,
World Mental Health Day.
Thank you for giving your this
Next year.
valuable time, ma'am, because this is really like having like taking out time for in this busy schedule, ma'am. You are having COVID duty also.
Yeah, besides COVID duty, I'm mother of 5.5 years old daughter.
Yeah.
And I'm a homemaker also, besides being a psychiatrist. So yes, home management is more, it's more taxing in comparison to my COVID duty management. Okay, thank you.
Thank you, ma'am. Thank you, participants. Thank you, Pavan, Surya,
Chalo,
Sevika. Thank you, Manu.
Thank you, sir. Thank you, sir.
Okay, chalo. Bye. Let's find out.
Hello. Good evening, sir. Sir, I'm sending you on WhatsApp. Sir, actually, today, ma'am had called me, Vijay Lakshmi ma'am, for duty, and she told me that to. Okay, sir. Thank you, sir. Hello. Yeah, Monica. Okay, okay. Yeah, 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 yeah. But tomorrow it's not my duty now. Yeah, Niva won't be there, but tomorrow is Sunday duty now. Yeah, yeah.